in high-risk non-muscle invasive bladder cancer, risk stratification currently is only based upon pathological criteria and clinical criteria. And these are, among other things, the multiplicity of the tumor or the size of the tumor, also whether there's carcinoma in situ, the stage and the grade. These are all very important to determine the risk of progressive disease and also the treatment of these patients. So there's a way to further enhance this clinical pathological staging, and that is by substaging. So if you actually look at the depth of invasion, and not only whether or not the tumor invades the stromal tissue, but also how deep it invades into the stromal tissue and how many locations it invades at the stromal tissue. You can also, well, and that is what our assumption was, is that maybe further improve stratification of these people, because we think that if you have very deep invasion of the stroma, the BCG probably works less efficiently. So we collected more than 550 patients. We performed centralized pathological review. Then we asked to the pathologist whether he could stage the tumor as either T1 microinvasion or T1 extensive invasion. And what we saw is that if you treat all these patients with BCG, and then you pick out the T1 patients, so we had roughly 300 of these patients, 1/3 of the patients would have microinvasive disease, and 2/3 of the patients has extensive invasive disease. And these 1/3 of the patients that had microinvasive disease, so T1 micro, had exact same risk of progression as the patients with as TA disease, so non-invasive disease. And the T1 extensive invasive disease, these patients has a much more increased risk of progression. And if we add this substaging to the current EAU guidelines and the EAU risk tools that we have, we can actually improve the current risk stratification that we have. So why would we do this? We now identify those patients with the highest risk of progressive disease. We might be able to combine this with other clinical pathological variables and either treat these patients primarily with a radical cystectomy and not even start with BCG, or maybe we can monitor these patients more closely and in the end improve their survival and their outcome.